There we go. Welcome to today's USET Echo, COVID Echo. Today is June 10th, not January, June 10th. And Emily, do you want to get us started with some housekeeping tips?
Yep. Good morning, everybody. If you haven't done so already, I'm going to invite you to mute yourself. Feel free to ask questions throughout the presentations. You are being recorded. The recording will be available probably by the end of the week or early next week on our YouTube page. And also, we are offering continuing education credits, nursing and medical, and in order to claim those, you need to complete the session today, and then you have to complete the evaluation, and the evaluation will lead you to filling out information on what kind of credit you would like. And I think that is all I have.
Okay, great. And we'll post that link towards the end of this session as well, so people that are just joining can add that. So today we have a full agenda of some wonderful EPIs that we have on staff. We have Imani Ransby, who's going to give the overview of the Nashville area COVID stats. Anna Garrett is going to talk about wastewater surveillance, and Emily Bear is going to talk about the Novavax vaccine, new updates for that. And we'll go ahead and get started and turn it over to Imani. Oh, I need to give you. There you go. You should be able to share now.
Thanks, Brian. Alrighty, so greetings everyone and happy Friday. Thanks for joining us for today's Echo session. I'm happy to report that we did update and launch the new COVID-19 surveillance and vaccination report. So everyone should have received those last week, Wednesday in particular. And we will continue to do monthly reporting going forward. There are a couple of tribal nations that have decided to continue on with weekly, and so we will continue doing that for them as well. But with the USET report specifically, that will be issued on a monthly basis. So the next round of reports will be going out in July, the first Wednesday in July to be exact. So that would be the 6th. So be on the lookout for that. And again, we will continue on that type of schedule the first Wednesday of each month going forward. So as Brian mentioned, today I'll be spending some time going over the new information that's included in the surveillance report and just give an overview of where we're getting this information from, as well as why we feel it's useful at this time in the pandemic. Alrighty, so I'm gonna just go ahead and jump ahead and go into the data sources that we are using to generate the new maps and graphs. So when we first started revamping the report, we discussed the importance of choosing data sources, and we not only wanted the information that would be the most useful to USET membership as far as how different geographic areas are being impacted by the pandemic, but also something that could be used as an early warning sign for influxes or cases and infection of SARS-CoV-2. So we can see that many places have somewhat transitioned to a stage where instead of primarily focusing on decreasing the spread of the virus, we are now kind of coming to terms with living with it. And so we have also kept that in mind as well. And so I do think that's attributed to having access to more resources than we did early on, such as vaccinations, even mask and protective equipment. I was just thinking back to early on in the pandemic where we did not have access to all of these things. And then also just the information that we now know about COVID-19 too. So that being said, as far as data sources, we did decide to kind of mirror some of the information that CDC has been putting out there, but also retaining a few of the data points that we had in the old reports So for the COVID-19 surveillance portion of the new report, we are using data from IHS. They send us a COVID-19 tracking sheet weekly on Tuesdays. So I'll go over what information in particular is being pulled from there. And then we do have quite a few CDC data sources that we are using, the COVID-19 community levels, as well as wastewater surveillance data, which Anna will go a lot more in depth than I will, but I will just touch on that. And then also data from HHS Protect, or Health and Human Services Protect COVID-19 Data Hub. So those are some of the data sources we are using to generate those COVID-19 surveillance reports. And then with the vaccination reports, those haven't really changed that much. We are still using IHS COVID-19 dashboard and advanced information, as well as CDC information from the COVID-19 data tracker. So that has remained relatively the same. So when you first open your PDF report for the USET area and you start at the top of the document, you'll notice that we do have a header area with some information regarding COVID-19 hospitalizations and COVID-19 test results at reporting facilities in the IHS Nashville area in the last week. And so we decided to include the current variant or variants of concern in this area as well, followed by that information that includes the number of positive test results in the last week. And again, some hospitalization information. So with the variants of concern, that's pretty much just a reminder to us, well, what is the current variant right now? So that's included there for you to review. And then, as I mentioned, HHS data is used for these reports, and that's what we are pulling from for the USET purchased and referred care delivery areas, and USET states for the total number of patients hospitalized with COVID-19. So this information is actually from this past Tuesday. I was able to update the information. As you know, the last report came out last week. So I just went ahead and updated as I was able to do so. And we can see that in the PERCTA USET area, there were 1,888 patients hospitalized with COVID-19. And then in the USET states area, there were 6,811. So with the IHS data, what you see for the total number of positive COVID-19 test results at reporting facilities in the IHS Nashville area in the last week, that's where we get that from. So it is travel nation specific or USET area specific. And I went ahead and updated that information as well for this current week, even though we did do a report last week and not this week. And that was at 165. It did go up from last week. We were at 41 cases in the past week, I believe. And that was mainly due to one of our tribal nations. They had a lot of cases that were reported. So that's why there is that big jump. And then the 7-day positivity rate has been at 11%. So many are likely already familiar with the community levels, but if you're not, these are categories that were created by CDC, and they're based on metrics for new COVID-19 admissions, as well as the percentage of staffed inpatient beds occupied by patients with COVID-19. And so we have a low, medium, high levels. A bit of a color change. We're using red for our high level while they have orange. But for the low levels, the indicators are new COVID-19 admissions per 100,000, and that is a 7-day total, as well as percent of staffed inpatient beds occupied by COVID-19 patients. And so if both of those are less than 10%, then it will be a low category. And then you can see the other specifications for the medium and high levels there as well. So with this map also, the thing that I wanted to point out is, well, what do we do if it's a low level? What do we do if it's a medium level? What do we do if it's a high level? So CDC says if you are seeing your area is in a low level to make sure that you are staying up to date with COVID-19 vaccines and boosters. You are maintaining improved ventilation throughout indoor spaces when possible, and that you're also following CDC recommendations for isolation and quarantine. Another thing to note with this low category is if you are immunocompromised or at high risk for severe disease, then to speak with your healthcare provider about maybe extra precautions you might need to take. CDC also lists out community level prevention strategies. So what I just mentioned were individual and household level prevention behaviors for the low level. Some community level prevention strategies that are recommended at the low level are to distribute and administer vaccines to achieve high community vaccination and ensure health equity. So again, making sure individuals are getting vaccinated and boosted. And a lot of the same things, actually. Improved ventilation, you want to make sure in public indoor spaces that's available. And then ensuring access to testing, including through point of care or even at-home tests as well. So those were some of the things they mentioned for the low level, as far as individual things that you can do, as well as community level based. At the high level, they are mentioning that if you are immunocompromised or high risk for severe disease, to definitely talk to your healthcare provider again, have a plan for rapid testing if it's needed, and also to consider testing your household or social contacts if they have been in contact with someone who's high risk for severe disease. In addition to all of that, you also want to do some of the same things you were doing at the low level as far as ventilation and following CDC recommendations for isolation and quarantine too. So when we get to the high level, that's where you really want to consider wearing a well-fitted mask indoors in public, regardless of your vaccination status. And then if you are immunocompromised, then to definitely wear a mask or a respirator that can provide you with some greater protection. So I wanted to just go ahead and go into the map itself. As I mentioned, this information is based off of CDC's community levels, and we are looking at USET states in particular here. And so really looking at this, we see that for USET states in particular, that Florida and Maine are currently being heavily impacted by cases, as they do have some red or high areas, but also the concentrated yellow in some of the USET states like North Carolina and South Carolina, you can also see. And if you look at the image for community levels in the US as a whole from our last echo, you'll also note that there has been an increase in admissions and cases since the last month, as a lot of those areas were showing more green back then. So about a month ago, but now we're starting to see some yellow and then definitely some red too, or orange. So moving on to this next map that's showcased in the surveillance portion of the report, we have wastewater data, which is very exciting. I won't spend too much time here, as I mentioned, Anna will go into more detail with that, but we did decide to go with this metric of percentage of wastewater samples with COVID-19. And the darker the orange, the higher their percentage, the lighter the orange, the lower the percentage. And we will be adding in a legend on the report so that is more evident going forward, as well as some additional information. You may have noticed there was a Word document also attached with the reports that kind of went through the wastewater data portion. And we'll also add some extra stuff in there for community levels and the HHS data that I've mentioned as well. So yes, wastewater data specifically can be used as an early warning sign for increases in infection. So we do feel that incorporating this specifically into the report can be a very useful tool in addressing COVID-19, especially as we get more and more data. you will notice that some of these areas that are just white, we don't have information for. So it's slowly trickling in, and hopefully in upcoming weeks, we will have something to report for you all in the tribe-specific reports, as many may notice that there's no data available right now. But in time, I'm sure we'll have some more to report. Oops, back too far. So I just have a couple of more slides that focus on COVID-19 surveillance before moving on to the vaccination information. So here we have listed COVID-19 hospital admissions per 10,000. And this is as of 6/2/2022. So last Thursday. That's also another thing I wanted to mention with the community levels data. It's updated every Thursday. So we report on Wednesdays, so we might not have data available for that week specifically, but definitely the previous week, that Thursday. And so with COVID-19 hospital admissions, this also is obtained from the CDC community levels. And we created a USET PERCTA, a USET state, and a United States bars for each. And so with the USET PERCTA, we see that there were 144.48 COVID-19 hospital admissions per 10,000 as of that 6/2 date. And then there were 575.79 cases per 10,000 for the USET states. And lastly, 2,055.63 for the United States. And then again with this, I think as we're able to look back at information, we'll kind of see, well, has it gone up? Has it gone down since the past month? And so on. But this is what we have to report at this time. Moving on, we also have inpatient hospital bed utilization in the report. It gives you the percentage of total inpatient hospital beds used as of 6/7/2022. So that's for this week. And we pulled that on Tuesdays. So we do have information available for the current week for that. And from this, you can see that the USET PERCTA and USET states inpatient hospital bed utilization has kind of stayed the same over the past 3 months, April, May, and June, not drastically increasing or decreasing. But then my apologies, that was the USET PERCTA in US that I was referring to actually. But with the USET states, we do see it kind of dip down in May there to around 43%, and then went back up this month. So moving on to COVID-19 vaccination data, very important effort within the pandemic space. We've also been continuously reporting this, but I do want to mention that you'll notice that the change in percent has not changed that much for the reporting facilities in the IHS Nashville area. And that is going to be due to us reporting last week. As I mentioned, we did have a report then, but as we go to monthly, we'll see some larger increases, I assume. But yes, for the IHS Nashville area, the percentage of population fully vaccinated was at 53.1% for this week. And then the United States was at 66.7%. And lastly, IHS at 42.2%. With this image, we again have the percentage of population fully vaccinated, except we have all of the USET states listed out as well. So you can look at that information too. And it looks like the highest percent we're seeing amongst the USET states right now is within Rhode Island, I believe, with 84.5%. And then I think the lowest in Alabama with 51.5%. I also want to just make note that this information is also obtained from CDC, although that reporting facilities in the IHS Nashville area is obtained from VAMS, or the COVID-19 dashboard data that IHS sends over to us. Actually, daily, we have that information, but we do pull the Tuesday before we report. So with this one, we do have the percentage of population fully vaccinated that have received another dose of COVID-19 vaccine, and that's going to be additional doses as well as booster doses. At this time, we are not able to differentiate. So with that, we see that the percent was at 18 for reporting facilities in the IHS Nashville area. And again, here you can look at all of the USET states to just kind of see, well, what has happened since the past week. And that will be changing to the past month once we issue our next report in July. So instead of seeing 6, 7, and 531, we would see 6, 7 in probably July 5th, I want to say. So these are just several resources that if you're interested, I wanted to list out here. It's really in regards to where we're getting this information from as far as CDC. The variants of concern, that's where you'll find the information on that first link, COVID-19 community levels, some of the national COVID-19 wastewater surveillance, and then COVID-19 vaccinations in the United States, which comes from the COVID-19 data tracker. As always, please do feel free to contact us if you have any questions or concerns related to the COVID-19 reports. You can reach us at usetepi@usetinc.org, and we would be happy to assist you. And I will take questions.
Thank you, Amani. Do we have any questions for Amani at this time? Just a reminder to, if you haven't already, put your tribal affiliation in the chat box down at the bottom. That'll help us keep track of our reach. And next up, we have Anna Garrett, who's going to be talking about wastewater surveillance.
Hello, who is excited to learn about wastewater? All right, so we're going to be going over quickly what is wastewater surveillance, and then we're going to kind of dig into, let me share this a little bit differently, and then we're going to dig into, can you guys see that okay?
The 3 ellipses down below the screen, below the slide. Oh.
After all this time from COVID, I still cannot share my screen. Okay.
Yep. And then you change it to hide presenter view.
Okay. One moment. My screen is now frozen. So 1 second here. Just a struggle sometimes. All right.
There you go.
Okay. Can you see that okay?
Yes, we can.
Okay, perfect. So we're going to be going over, like I said, just what wastewater surveillance is, and then we'll be diving into the specific reports. Okay. I'm so sorry, my screen is frozen. And did the slide advance for you guys? Are you seeing that?
I think it like crashed, Anna. We can't
Okay.
see your slide.
That is amazing. I'm so sorry. All right. Let me see. We'll just share the screen and then hopefully that works better. Maybe.
You might want to put up the presentation first and then share your screen. That usually works for me because you can select the right one. Yeah, there you go.
How about that? Okay, perfect.
If it
All right,
doesn't
sorry
work, I can run it too.
Okay, I think we're good. I disconnected my other monitors. That might be the issue. Anyway, moving on. So what is wastewater surveillance? Basically, it's water-based epidemiology, just essentially looking in water, specifically wastewater, to get any type of clues or information on what might be going on with disease spread. So you can monitor a lot of different things in wastewater. We can look at different pathogens, different pharmaceuticals, toxins, chemicals. The graphic on the right here shows all the different things that we can look at. And so how this works is sewage samples are collected from each sewer system, obviously before they reach that water treatment plant, and then they are sent off to the lab. So this timing can be variable depending on where exactly the sample is collected. Sometimes they're collected right before they reach the wastewater treatment plant. Sometimes they can be collected a little bit earlier on in the sewage system. It just does depend kind of where those different access points are. And then they would be transported to whichever laboratory is doing that testing. And then they would run whichever test they were doing to, determine the amount, or if any of the pathogen, chemical, pharmaceutical, whatnot is detected or not. So historically, just a fun fact, this water-based epidemiology traces all the way back to the origins of epidemiology and Dr. John Snow during the Broad Street cholera outbreak. He actually used water, which was, determined to be the cause of cholera. So this has been going on for a very long time. So nothing new here. The new part is just detecting COVID or SARS-CoV-2 through the wastewater. And this was actually used back in the 1940s in the United States to track polio outbreaks. So this has been going on for quite some time. So like we were mentioning, the CDC launched this national wastewater surveillance system back in September of 2020. And it's to track SARS-CoV-2 levels in the wastewater. So if you see here, this is just a screenshot of their website. It's publicly available. So if you're interested, you can definitely head over there. And they actually do all of these little dots that you see here that are color coded are all of the different wastewater treatment testing locations. They do have 3 different metrics here in this top left corner that we're going to go into what those mean. And then on their website, there is additional information, and they are adding new sites every single day. Even from when I had pulled the data for the monthly report on the 31st, I looked again, there's more sites. So lots and lots of new sites being added every day. So hopefully the information here is going to get a little bit stronger over time. So how exactly does this work for COVID? So essentially, symptomatic or asymptomatic individuals, they have COVID, they go to the bathroom, SARS-CoV-2 is shed in their feces, it transports down into the sewage system. They take the wastewater samples at the treatment plant before any treatment has occurred to that water, or at a different, testing point between, the individual's house and the wastewater site. And then it's sent to the lab and they look for any of the SARS-CoV-2 variants, how much is there, all of the different metrics that we get out. And then this information is reported back publicly to us, and also some more granular data on the Decipher portal. So how this works. So the data that's publicly available right now from the CDC, that's what's online, and that is what we are using currently in these reports. So about 40 to 50% of people infected, even asymptomatic people, like I mentioned, with COVID-19 shed this viral RNA in their feces. About 80% of the US is actually represented in this wastewater sampling or is connected to a sewer system. This data is submitted either from state, tribal, local, or territorial health departments, either voluntarily participating in the National Wastewater Surveillance System or from a CDC managed contract for commercial testing. And this is just a really good method to use, as Amani was mentioning, because it can indicate disease trends 2 to 14 days earlier than clinical testing. And there is just such a wide range in that because of, the transportation time of, from the wastewater treatment site to some of the laboratories. Some of those little things can kind of impact the timing of how early we can indicate these disease trends. And wastewater surveillance is just really good because you don't have to go out to a medical facility and seek care. You don't have to take a test. You just have to, do what you're normally doing, going to the bathroom. And it's just a good kind of general overview of what might be going on in the community, kind of as an overall level. So it really encompasses a lot more people than those who seek out care. And like I want to mention, it does work best in addition to other data sources. Just looking at the wastewater is not going to give you a full picture of what's going on in the community, but it does pair nicely with the other metrics we have included in these monthly or weekly reports. So I do just want to point out some exceptions quickly that are not reported by the CDC. So any sewer sheds serving less than 3,000 people, this is just due to privacy concerns, just with those, lower level of people. Anywhere where population estimates are missing, any data specifically from a facility or institution, if there are any data quality issues, and then obviously households on septic systems would not be included in this. And I am currently working with a representative from CDC to try to gain access to the Decipher portal, which would be more granular data for these monthly and weekly reports. So if your tribal nation does have a wastewater surveillance system or just a wastewater system, and you're interested in participating in this, or interested in USET having access to that data, you may or may not be getting an email from them. So now we're going to go over the CDC Metrics Online. So there are 3 different ones. So the first one is the current virus levels in wastewater by site. So I do want to mention that this is not the overall level of SARS-CoV-2 in the wastewater. It basically is showing if these levels are either higher or lower than the past levels at that same site. So it's very site specific, kind of as a comparison method to previous levels. So these levels are grouped into 5 different categories that you can see there. Basically 0 to 19% being the lowest level, and then 80 to 100% being the highest level they've ever seen. There is also a metric percent change in the last 15 days, and this is how much the normalized SARS-CoV-2 viral levels in the wastewater have either increased or decreased in the current 15-day period by percentage. There are some gaps in data with this one if they might change lab or change what specific test they're using. And it is just a percent change, so it just reads out as a percentage. It doesn't give any indication of, how many units that might be. So 100% change could be going from 1 unit to 2 units, or it could be 500,000 units to 1 million units. It's hard to tell kind of exactly what that might mean in context of what might be going on actually in that wastewater. And then the final metric, which is the metric we decided to go with, was the percent of wastewater samples with the detectable SARS-CoV-2 in the last 15 days. So this is just the percentage of samples that are positive for that SARS-CoV-2. So basically all the samples they get, any ones that are positive divided by the total number of samples times 100. So like I mentioned, this is the only metric that is included in the report for now. It's the best one we think that is availably, publicly accessible. Hopefully when we do get access to that Decipher portal, we might get some more, specific data, but we are using what we have for now. This is a metric that's most easily comparable between sites. So the CDC data is reported by sewershed, and it lists all states and counties covered. So for example, some sewersheds cover, only one county in a state. Some might cover 7 counties in a state. It really just depends, where that sewershed covers. Sewersheds obviously don't care about county lines. So if it, touches in any county, it would be counted for that county. So this data is then aggregated according to the states or counties each individual tribal nation has territory in, and then combined into one metric. So say a tribal nation covers, it has multiple counties in different states, or there's multiple counties within one state. I take that into consideration, and then all of that information is aggregated into one metric. But if you are interested in looking at a specific sewershed online, you can do that and sort by state and then kind of zoom in and see which specific sewershed you might want to look at if you're interested in just one specific area. So this is really most useful when COVID-19 levels are low in the community, and then we would easily be able to kind of detect these surges coming. And I do just want to note, if there is, 0% of wastewater samples with detectable virus, it doesn't necessarily mean that there is no COVID in the community. It just means, within those samples collected, there was not any. So I do just kind of want to make that distinction. So this is the same graph or map that Amani showed. We did decide to update the colors to a nice pretty blue. And you can see here in the top, white is 0% or no, data reported. And then it goes all the way up to this dark blue, 100%. So you can see here, Texas is at 100% of samples showing that SARS-CoV-2, whereas some places like, for example, New York, they have a lighter blue, just indicating there was less of that SARS-CoV-2 in those wastewater samples. So this kind of gives a good, overview of what's going on in the United States. If you're possibly traveling, living somewhere else, working remote, anything like that. So I have kind of 3 different examples of what you might see in your report. We are going to be changing this detectable COVID-19 to SARS-CoV-2 just to be a little bit more specific. So like I said, this isn't necessarily Eastern Band of Cherokee Indians wastewater plant. It's just aggregated data from the sewer sheds and counties with, within that area they hold territory. So you might look like this, where both of EBCI and North Carolina have that 100% average of those sewer sheds, and then the minimum and maximum are with 100%. So every single sample, within North Carolina and those counties, was positive for SARS-CoV-2. So that would be most useful if, you were coming off a period that there wasn't very much and there was a surge, but just this with itself doesn't necessarily tell you too much or would influence that many, decisions. We also do have over here, it could look like this, where the specific counties for St. Regis Mohawk tribe, they did not have any, it was 0%. None of those samples did have that COVID-19, whereas the whole state of New York, they did just have a little. So it could look like that, where there are kind of different metrics for, the tribal nation and the state. It could also look like down here at the bottom, where there was no information for the tribal nation, for those specific counties that it covered, but there was information for the state overall. So it could look like that, where you're just kind of giving the overview of the state. Also, you might get one that just says no data reported, meaning there's no data for either the state or your specific tribal nation. So those are the three, or I guess four kind of outputs that it might look like on your specific reports. And you can kind of just take this with a grain of salt and kind of just consider the other metrics as well. But it is just something to keep an eye on. And then, like I was saying earlier, this metric is over kind of that 2-week period. So if you are one of those tribal nations getting a weekly report, you won't necessarily be getting that wastewater data every single week, since it does only update, during that 2-week period. So you might have some gaps there, which is, not unexpected, but we will just write that in there for you. And then the data is publicly available on the CDC website. It is updated every single day. So if you do want to keep checking back, you may have a new wastewater site within, your area. And then I will be able to take questions if you have any, or if you have any specific questions from your report, you can always just email us. And then sources.
Great. Thank you so much for that wonderful presentation. I have a couple questions. So what test are they actually doing, and is it reliable?
Yes, so it is a PCR test. The specific one is dependent on, which lab, since not, all the labs are the same. But for example, for that second metric, if there's like a % change and they do change the exact type of PCR testing they're doing, they won't be reporting that metric. So it does seem to be pretty reliable generally at picking up that SARS-CoV-2 in the wastewater. But they are kind of all different depending on, which wastewater treatment site you're using and which lab they're using. So that's not super helpful, but it is a PCR test, and they are taking into account if that, method is changed, they're updating the data accordingly.
Awesome. And I have another question. When does the body start to shed the virus in the feces?
That is actually a really good question. Let me actually just double check so I don't give you the wrong information. I believe it is the same, the 2 days before your symptoms or, your positive test, like it is for kind of that contact tracing, but I will double check and I will go ahead and put that information in the chat just so I'm not providing the wrong information, but I believe it is the same kind of as that, respiratory.
Okay, great. Thank you. Are there any other questions for Anna? Hearing none, we can move on to Emily Bear's presentation on the Novavax.
Okay, so you can see that okay?
Yes.
Thanks. All right, so yes, I'm going to be talking about the Novavax COVID-19 vaccine today. I believe we've gone over this a little bit in the past. I think Dr. Brown might have presented on it. This is because VRBPAC just recently voted to authorize the vaccine, which is super exciting. I also have at the end just some updates on the status of the younger group COVID-19 vaccines for pediatric recipients. I know we do have the echo set aside for an hour and a half, but I'm gonna try to get us out hopefully by the hour. So I might skip over some of these slides just as an FYI, but they will be available to you after. So just getting right into it. The Novavax COVID-19 vaccine is a vaccine designed to prevent COVID caused by SARS-CoV-2, specifically in individuals 18 years of age and older. They, I believe, have expanded it to an adolescent population, but at the moment we're just talking about the use in adult populations. It is a recombinant protein vaccine with a naturally derived adjuvant. It uses a full-length wild-type SARS-CoV-2 S protein of the original SARS sequence, SARS-CoV-2 sequence from Wuhan. Saponin or soap bark tree-based adjuvant is used to strengthen the immune response to the virus information. And in this case, that virus information is the spike protein of the SARS-CoV-2 virus. They formulate it as a nanoparticle, so it can't cause the disease itself, but it can elicit that immune response. So I'm trying to contain my excitement throughout the presentation, but there's a lot of exciting reasons that we've been looking forward to Novavax. So one is that it is a recombinant protein vaccine, and this is kind of a tried and true vaccine technology. So it's not something that people can say is like experimental or new like the mRNA vaccines. At the moment, approved recombinant protein vaccines exist for flu, hepatitis, HPV, meningococcal B, shingles, and there are approved vaccines that also use that saponin-based adjuvant for malaria and shingles. So it's really based on vaccine technology that's existed and been proven to be effective over time. Now, how the Novavax vaccine works is that SARS-CoV-2 spike gene information from the original strain is, well, it's actually inserted in a baculovirus cell, and then that is inserted into a fall armyworm moth cell. So you might have heard of us like growing flu vaccine in egg cells and stuff like that. And this is kind of similar. So it's being grown in a moth cell. And in there, the moth cell can decode that information. It will display the spikes that we're familiar with from the SARS-CoV-2 virion on the outside of the cell. Then they can basically, I guess, harvest is the right term, those spike proteins. And you follow the first green arrow from the number 2, the first image right there, you see them assembling those nanoparticles with the harvested spikes. And then they use, once those are assembled, essentially the adjuvant is added, and that is what makes up your vaccine. And the last couple images there are just showing the vaccine being injected, and then finally the immune system doing its thing. As far as the vaccine dosage and the clinical trial, dosage-wise, it's 0.5 milliliters per dose. I believe that's similar to Moderna. It is another 2-dose vaccine, so a primary dose and what is essentially a booster dose to complete your primary series. And it is given 3 weeks or 21 days apart. I think the WHO does allow right now for 3 to 4 weeks, where it's licensed in other countries at the moment. It comes in 10 doses per vial. And another kind of cool thing about Novavax is that it was manufactured specifically to be stable at 2 to 8 degrees Celsius, so at refrigeration temps. It doesn't need any special storage or handling in requirements. The clinical trial, or study 301, was performed in the US and Mexico. It was about 94% of participants were drawn from the US. It's a randomized, observer-blind, placebo-controlled phase 3 trial, and it had about 30,000 trial participants in total. They randomized them 2-to-1, so 2 times as many vaccine recipients in comparison to placebo recipients. So there were 20,000 in the vaccine group and about 10,000 in the placebo group before crossover. And crossover just means after the study was done, they were allowed to receive the other, whatever they didn't receive. So placebo got the vaccine and vaccine could get the placebo to complete their study period. Demographics wise, it was about 52% male, 48% female, 75% white, and 6.7% American Indian Alaska Native. I believe Novavax is one of the vaccines that did outreach to different tribal nations across the country. And I know that I can't remember all of them, but there have been some presentations from tribal nations that actually did participate in the study, talking about their experience and getting their community members vaccinated before other populations. So that's pretty cool. And I appreciate, of course, I'm sure we all appreciate, nice to see that they're making efforts to include Native people in their study, and that they had, as far as I can tell from the presentations I'm seeing, a respectful experience. Safety data collection is still ongoing, and we will talk about that a little bit more in a couple slides. Vaccine efficacy. So we've been hearing about Novavax since pretty much the start of COVID, right? Like I think the first report started around June 2020, and they did submit for an EUA last year, and then we didn't really hear anything since. But overall efficacy, initial reports were really positive, and this evidence from the FDA and from Novavax from their recent meeting does show that very high efficacy rate. So you can see it's about 90% effective against COVID-19. That holds up with the population with medical comorbidities who are in the study. And it is just like the mRNA vaccines, it was 100% effective against moderate and severe disease. As far as its effectiveness against variants, at the bottom, it says 94% effective against alpha and 93% against all variants of interest and variants of concern. I did want to draw your attention to the bullet points to note that at the time the study took place, the variants of concern in the, US and Mexico were alpha, beta, epsilon, and gamma, and the variants of interest were delta, iota, kappa, and zeta. And as I'm sure you're aware, and from Imani's presentation, we saw the circulating variants right now are all Omicron or Omicron subvariants. So this wasn't really studied against Omicron, and I think it would be reasonable to conclude that it is probably going to experience a drop in efficacy once there's more real-world evidence, just like we've seen with other vaccines. However, it's still a really high efficacy rate. And so I would expect that the drop will, be similar more to the mRNA vaccines rather than to something like J&J. And that is to say that there will be still a significant amount of protection, and especially against moderate and severe disease. As far as vaccine efficacy across subgroups, overall 90% efficacy, as I mentioned, specifically for American Indians and Alaska Natives. You can see the effect estimate is in the yellow circle, and it was a little bit higher than at 92% than the overall estimate. However, that grayish bar represents the confidence interval, and you can see it's extremely wide, and that kind of indicates that because of that low number of cases, just 1 case in the Novavax group and 6 in the placebo group, that because of that low number of cases, we have less certainty about where that effect actually lies. So it might be somewhat higher. It could also be lower. Other subgroups and efficacy. It held up really well, like we said, against severe disease, so 100% effective, no cases at all in the vaccine group. It held up well for those with comorbidities and those in the younger 18 to 64 year age group, where there's less certainty and a significant drop in efficacy is the older 65 years and up age group. And you can see that that effect is just 79%. Again, that is something we've seen with other vaccines being less effective in older age groups. So it's not necessarily unexpected, but it is something to note. I'm going to go through a few slides on safety. I'm actually going to skip this one. It's not that relevant, but I did want to talk about the local and systemic events and any adverse events that are associated with the vaccine. So in this graph, you can see it's split into the top, which is the 18 to 64-year-old age group. And then at the bottom, there's the 65-year and up age group. And this is local events at the injection site for dose 1. And the next slide will be for dose 2. You're looking at grade 1 to 2 or mild to moderate symptoms in blue and severe symptoms in yellow. So for dose 1, you can see that pain and tenderness was the most common symptom reported in both groups, and those were all mild to moderate, almost all mild to moderate symptoms. And it is the same for dose 2, with the younger group experiencing a few more severe local events with pain and tenderness than the older group. As far as systemic events, so those symptoms that we experience after vaccination, but not necessarily at the injection site. So stuff like fever and fatigue and headache that many of us experience after COVID vaccines. In the 18 to 64-year-old age group, it's pretty much confined to fatigue, muscle pain, and headache is the most common. And again, those were mostly mild to moderate. In the 65 years and up group, very similar fatigue, muscle pain, and headache, and also mild to moderate for dose 1. For dose 2, we're again seeing that pattern with a stronger immune response where symptoms are more frequently reported, especially for the younger group, and they are more severe in nature. And that's something you see across vaccines, and you especially see with the COVID vaccines that older individuals may have like a less strong immune response, so they might experience fewer of these symptoms, whereas younger people are experiencing stronger symptoms and more frequent symptoms. So in the top group, that's pretty much across every symptom category that you could have. There's at least a proportion of individuals experiencing them. With adverse events, in the blue bars, that's the vaccine recipients. In gray, that's placebo group. And at the bottom, that is the percentage of participants who are reporting any of these adverse events, such as nervous system disorders, gastrointestinal disorders, and so on. The things to note here are that pretty much in each category, the proportion across groups are similar, or treatment arms are similar. And overall, those percentages, the highest is only 3.1% reporting infections and infestations. So very low in frequency overall to report an adverse event. These events were observed in the study through day 49 or 28 days after dose 2. Serious adverse events, similar graph format. So we're looking at percentage of participants on the bottom who reported something, and we're looking at the blue Novavax group and gray placebo group. And again, this is very low percentages of reporting any serious adverse events. That includes cardiac disorders, so stuff like myocarditis, which I'll talk about on the next slide, and nervous system disorders like Guillain-Barré syndrome. Again, similar across study groups and very low frequency. So I'm sure we're all familiar with the concerns of myocarditis and pericarditis that were linked to the mRNA vaccines in particular, especially for younger men. And that is something that Novavax, I guess, like knew to look for because of the previous vaccines, and the FDA specifically is evaluating COVID-19 vaccines for at this point. So of the 744,000 doses administered globally as of April 30th this year, there were 35 reports of myocarditis or pericarditis. These were spontaneous reports. So basically, if someone had myocarditis or pericarditis and it might have, like their provider thought it might have been due to the vaccine, they would report it. So kind of like VARS, VAERS, VARS or something, except it's global. So this is getting reported differently. None of those actually met the Brighton collaboration definitive case definition. So they're considered potential cases. And interestingly, they weren't actually in younger like men. We didn't see the same demographic case pattern here. It was primarily men, 10 cases of pericarditis with 3 female cases, but the median age was 42 years. And all cases were from Australia. So there weren't other cases reported in all the other countries that have authorized Novavax, which is an interesting note. In the total clinical safety database of 40,000 vaccine recipients, 6 reported myocarditis and or pericarditis. So that's data that's coming from all recipients who've agreed to be part of this database, essentially, and the FDA analyzes this data set after Novavax to confirm their results. So this is kind of the FDA's take on the myocarditis risk. After that analysis, the FDA did not conclude that there was a causal link, but they did decide to list it as a potential risk. So it's kind of good news and bad news. There's 2 possibilities where with more doses, with authorization in the US and more doses being administered, it's possible there will be more cases and it'll be linked back. It's also possible that there will be fewer cases or like no cases and they're able to rule out that link. So I'm not really sure what direction it will go in, but it is definitely something to keep an eye on. As far as other events of interest, really good news here, actually. No cases of anaphylactic reactions. So this should have a lower allergic response for people who might be allergic to ingredients in other vaccines. And there were also no cases of thrombosis with thrombocytopenia, which is that very severe blood clotting disorder that's linked to the J&J vaccine. There was one case of neuropathy that met the Brighton collaboration definitive criteria for Guillain-Barré syndrome. So I believe this FDA did decide to include a potential warning for that as well. And then the final note here is that while it wasn't specifically evaluated in pregnant individuals yet, I believe they've expanded, like they have a separate study for that now. But of course, it does tend to happen during these studies. That's what happened with Pfizer, Moderna. That's how these companies are able to evaluate pregnancy outcomes just due to pregnancy occurring within participants. And their evaluation of Novavax's outcomes for pregnancy showed no potential risk for a mother or fetus. I would guess based on information from the other vaccines, once they do release their trial data for pregnant individuals, that they will probably continue to show no risk. Although at the moment, FDA is not going to, of course, like authorize it in this population without that data. So benefits of Novavax and reasons, I guess, to be kind of excited about it. Definitely high efficacy and safety against numerous variants, and hopefully is going to keep holding up against the Omicron variants and subvariants. The immune enhancing adjuvant, so that soap bark adjuvant means you can attain that high efficacy with less reactogenicity. So the goal essentially is fewer side effects. I think it seems reasonable to conclude that the no allergic reactions, for example, is a really good example of less reactogenicity. And I personally have not seen whether there's been any comparisons, any studies with other COVID vaccines as far as local and systemic reactions. But theoretically, I think Novavax's goal is that the symptoms would be lower. Like I said, I haven't seen the data though, so I can't say that for sure. The majority of adverse events were mild to moderate in severity, and they did resolve in 1 to 2 days. That myocarditis, pericarditis risk still does remain and is going to be followed in further safety data. However, it does offer a more traditional vaccine choice that people might be more amenable to, since they've most likely received vaccines using that technology throughout their lives, really, at least in the US. And then there's 2 other points not on here that I wanted to bring up, and it just relates to vaccine hesitancy and increasing vaccine uptake. I'm hopeful that Novavax is going to, I'm slightly hopeful with reservations, hopeful that Novavax will be able to appeal to that remaining minority of the US population that has not received a COVID-19 vaccine yet, or is opposed to receiving the ones that exist, for 2 reasons besides that it's more traditional. The first is that there is, this is authorized by the WHO and has been for a while, so it's been used in at least 14 countries worldwide over, I want to say at least a year, probably around a year now, with no additional safety concerns reported and high efficacy still reported. And that includes countries like Australia, the UK, I think Singapore, Thailand, places like that. So it's not something that's, I guess, that new and has been used before it's getting authorized in the US. Secondly, one of the main reasons that people do cite for things like a religious exemption for a vaccine is the use of fetal cell lines in the vaccine. Obviously, vaccines don't use fetal cells in the vaccine themselves, but certain vaccines, like, well, many, like the mRNA vaccines, do use them in the development of the vaccine, and some even use them in the production. Novavax is very committed to not using fetal cell lines and does not use them in the development, production, or manufacturing of the vaccine. So there's hope that possibly this will be a vaccine that people will be able to get that kind of, I was going to say overcomes a religious exemption, but actually just provides them an alternative that they're comfortable with, is what I meant to say. So we will see with authorization if that does occur. And wrapping up here, just going over the COVID-19 vaccine approval process quickly, you can see here in the first 2 dots, that is where Novavax submits for an EUA, or an emergency use authorization, and then the FDA Vaccines and Related Biological Products Advisory Committee has to meet on it and review and analyze all the data and decide whether they should vote in favor. And so they did that just this week on June 7th, and they did vote in favor. Once that happens, the decision has to go to the FDA for final authorization, like legal authorization. FDA usually follows VRBPAC's decision. However, right before the meeting on June 3rd, Novavax actually had to let the FDA know that they changed some of their manufacturing process. And that means the FDA needs to actually review all of those changes due to regulations before they can issue an EUA. So I was really hoping today to come here and say, hey, Novavax is authorized, but unfortunately it looks like we're going to have to wait another couple weeks. The good news is it's very unlikely they're going to it's very unlikely they're not going to sign it. So we should have an EUA by mid-July, hopefully. And then the final steps before administration, the CDC does need to approve it. I don't know whether ACIP is going to meet on this, but if they do, that should only delay it by a couple days. And it's unlikely that they would vote against the FDA in any scenario like this. So after that, we should hopefully be able to begin administration of Novavax to the public by end of July, probably. These are some resources, just the FDA slides, the WHO's information on Novavax as well, which I found super helpful, and then a few articles explaining how it works that might be helpful in the future, just for personal interest or just if someone has questions about it when you begin administration. And finally, this is my last slide, I promise. Finally, status of COVID-19 pediatric vaccines. I just wanted to end here because I know we've kind of talked about this on and off for the months and have really received very little news. So we're doing our best to keep you as updated as we can. And I thought it would be helpful to include this here. Next week, VRBPAC, that advisory committee for the FDA, is meeting to discuss both Moderna's pediatric and adolescent vaccines, so for 6 to 17 years old, and for Moderna's pediatric recipients for that younger age group through 5 years of old who has no vaccine available to them yet. They're also going to discuss Pfizer's EUA for their youngest pediatric vaccine for those who are 6 months to 4 years old. And if you were on the February ECHO, we did a whole presentation on Pfizer's vaccine before we found out that FDA was going to be postponing this meeting. And this is that postponed meeting. So 4 months later, we're very excited for next week. And we will be sure to keep you all posted as to what the developments are. Going back to that process as far as approval, ACIP is definitely going to have to meet after this before any administration can change, but that usually only takes a few days. So we should know by next week what the approval looks like, and hopefully by the week after, administration and shipping the vaccines can begin. I included all the VRBPAC links. They will put up meeting materials if you want to use any of those materials or review them at all, like slides and everything, as well as a briefing document. And then I also included the meeting live streams. They're open to the public, and we always attend as much as we possibly can. And if you are able to, it's definitely an interesting meeting to be a part of. But that is all I have. Again, as you've heard, happy to take any questions. I'm going to stop screen sharing because I know there's some chats. But yeah, if anyone has any questions about anything we've covered or questions about distribution of pediatric vaccines, for example, next week, yeah, just reach out to us. Thank you.
Thank you for a great presentation, Emily. Do we have any questions? I know I have a question, but do we have any other questions for Emily at this time? Okay, my question is the saponin. What is that? The tree bark stuff.
I have a very terrible understanding of that, Brian. So you would ask that. My understanding is it's just a material that's going to help the immune system recognize those spike proteins and respond better versus like a chemical adjuvant, which can also increase the likelihood of experiencing symptoms. But
Okay.
I don't really know.
So it's not like a miracle drug or something that we all should be taking a capsule of every day.
No, I don't think it's anything like that. I think they are trying to move towards stuff like that, though, because it probably appeals to a broader audience.
More natural.
Yep.
Yeah. Okay. I thought it was going to be some miracle stuff. Okay, do we have any other questions for Emily or any of the other panelists? Okay, we can go ahead and conclude for today. The continuing education credit survey is in the chat. Oh, Dr. Brown said it is natural. So fill out the survey, even if you're not going for continuing education credits. It'd be helpful to get some feedback on today's echo. Otherwise, y'all have a great day and great weekend. Thank you all. See you next month.